Hi everyone, this is Evan Wilson, one of the third-year McMaster Radiology residents. Welcome to your next video on our McMaster Clinical Skills Radiology series. Today we're going to talk about abdominal radiograph anatomy. All the images that you see today on this video will all be normal abdominal radiographs, so no pathologies, and the idea behind this video is just to get a good idea of what you're looking at on an abdominal radiograph in terms of anatomy before we move on to our pathologies video. So what anatomy will we be talking about? We'll look at bony anatomy, and then we'll go on to soft tissues and organs that we can see on an abdominal x-ray, and then we'll move on to bowel anatomy. Usually the reason that an abdominal radiograph gets ordered is to assess for a bowel pathology, but it's important not to neglect these other anatomical structures that we can see, because often, although an abdominal radiograph isn't ordered to assess these structures typically, you can often see important incidental findings, which may become important in a patient's care if they're seen incidentally on these films. So we'll start off with bony anatomy. What structures can we see? We'll just kind of work our way from the top to the bottom. So first you see the ribs. Usually can see at least a handful of the inferior pairs of ribs. Some of them you can see the entire rib, and some you can only see kind of the lateral and anterior aspect because of the way that the ribs project kind of inferiorly as they move more anterior. And just for landmarking purposes, you can usually see T12 being the last pair of ribs that you see inferiorly, and that will correspond to the T12 vertebral body that we see here. If we move more centrally to the spine, we can see the bottom part of your thoracic spine and usually your entire lumbar spine. And you can see both the vertebral bodies and then the transverse processes projecting out to the side. You can even see parts of the pedicles, which are kind of these circles on the lateral aspects, which are connecting your vertebral body to the posterior element. And you can also see these spinous processes, which are these central bony structures that I'm hovering over right now. Moving more inferiorly, we come to the sacrum. And in the sacrum, you can see these paired structures bilaterally. Just a few are labeled here, but you can see more as you move more inferiorly in the sacrum. And those are your sacral foramina. So those are the foramina where your nerve roots will exit the spinal canal on their way out of the sacrum. Moving on, we have your iliac bones forming a large part of the pelvis. You can even see just one sliver of the pubic bones as well. And you can also see your acetabuli bilaterally, where your femoral heads can articulate to form your hip joint. And then of course we also see our proximal femurs and most prominently the femoral head, so that rounded area of bone that's articulating within the acetabulum in the pelvis to make the hip joint. And when you're looking at all these bones on an abdominal radiograph, again, it's not a dedicated study to assess the bones, but really you want to look for any abnormal contours that could indicate a fracture, specifically of the cortex on the outer aspect of the bone, and any kind of suspicious lesion, whether it's like a sclerotic too bright of an area or a lytic too dark of an area within a bone that catches your attention. Those are some of the main things that you'll just be screening for when you look at the bones. So we'll move on from the bony anatomy to soft tissue anatomy. Again, we'll start from the top and sort of work our way down. So if we look up in the right upper quadrant first, we see this structure with this edge here. And that will be the liver. If we look in the left upper quadrant, we see a similar edge. It's not quite as apparent as the edge was in the right upper quadrant that the liver formed, but that will be our spleen. And the reason it's not quite as apparent is because usually the stomach's in the left upper quadrant and the spleen's a little bit of a smaller organ, and that gas from the stomach just obscures that margin of the spleen a little bit more than if it's obscured from bowel in the right upper quadrant. If we look on both sides, particularly on the left side of the patient, we can see this outline here, and that forms the kidney outline. On the right side in this patient, it's a little bit harder to see. You can definitely see the inferior aspect here, and then we're losing it as we move more upwards into the right upper quadrant. And it's important to know that it's not abnormal if you can't see these structures. Typically, in this patient, it's a pretty good example of being able to see a lot of the soft tissues, but very often due to various reasons, technique, quality of the study, position of the bowel and overlying bowel gas, it can be very difficult to see these structures, and it doesn't mean there's an abnormality if you can't see them. So we talked about the kidneys. Moving more inferiorly, we can see there's a line or edge extending down the entire abdomen here, and then also on the other side. And what that is it's outlining the edge of the psoas muscles, which are originating along the thoracolumbar spine and extending downwards toward the pelvis to eventually insert on your femora bilaterally. And those are going to be powerful hip flexors that we can often see on radiograph. It's rare that you'll see a pathology in the psoas muscles on radiograph, but it is good to know that they're there and to look out for them. So when we move on to bowel anatomy, there's just one really important concept that we'll touch upon today, and then we'll talk more about in when we go over our pathology video, because it's easier to see some of these principles when there actually is pathology, which we're not looking at today. But the principle is that small bowel is typically in the middle of the abdomen, and it contains circular folds that cross the entire width of the lumen of the bowel. And those are called plicae circularis or valvulae conniventis. Those terms are synonymous with each other. And then the large bowel is typically in the periphery of the abdomen, forming kind of like a picture frame around the outside of the abdomen. And it contains folds that don't cross the entire width of the bowel lumen. They just kind of create an indent in the bowel lumen, but you can't see a line going across the entire width of the lumen. And those are called haustra. So if we look at our bowel anatomy, and again, we'll kind of work our way from top to bottom or proximal to distal. So in the upper abdomen, what stands out is this kind of gas opacity here, or lucency. And that is the stomach bubble. In this case, it's pretty collapsed. You'll often see a lot more prominent of a stomach bubble than this. So if it looks quite a bit more prominent than this, it doesn't necessarily mean there's a pathology. Although if there is an obstruction, the stomach can get quite dilated, which does sometimes indicate pathology. And then moving on to the center of the abdomen, more distally, we can see, in this case, it's pretty difficult to see, but we can see several loops of small bowel, particularly this one gas-containing loop here. There are a few other subtle loops in the middle of the abdomen. In this case, we mostly know they're small bowel because we can see the large bowel really well, and they're not continuous with the small bowel, as well as their location in the central abdomen. But sometimes it can be difficult to see if there's not a lot of gas within the bowel loops. You might not be seeing very much small bowel at all. Moving on more distally to the bowel, we have this, like we said, big picture frame loop of bowel kind of going all the way around the outside of the abdomen. In this case, it's quite full of stool. We can see kind of that bubbly appearance of air scattered throughout the lumen of this bowel loop, and that stool within the colon. So that whole thing forming that picture frame around the outside of the abdomen is your large bowel. And then as it goes into the pelvis, we can't see it quite clearly connecting to the descending colon in the left side of the abdomen, but this will be a rectosigmoid in the pelvis. You can't always see a clear connection between all the bowel loops. In this case, though, we can see pretty well almost the entire colon, which isn't always the case, but it tends to be a little bit more easily visible than a lot of small bowel loops in the central abdomen. And in this case, since we can see it so well, we can really outline the anatomy of all its different segments. So the most proximal segment is the cecum here. The ileocecal valve would be entering somewhere in here, but you can't see that on this radiograph. That then leads into the ascending colon, which folds at the hepatic flexure into the transverse colon, going across the upper abdomen. That then leads into the splenic flexure in the left upper quadrant, leading into the descending colon. And then we can't quite see the connection, but the descending colon will then lead into the rectosigmoid. More sigmoid in this region, and then rectum in the pelvis. So that's it for today's video. We talked about the bony anatomy, the soft tissues and the organs, and then we went over the bowel anatomy. So hopefully that served as either a good overview or a good review of some of the anatomical structures you can see within the abdomen on a radiograph. And we'll see you next time for our talk on bowel pathologies.